Good evening, everybody. We're going to start our webinar on COVID-19 vaccines and will they be safe? And I want to thank everybody for joining us tonight. Most importantly, we are honored to introduce our brand new chairman of the Department of Pediatrics, Dr. Sally Permer, who has joined us today. Dr. Permer is our pediatrician in chief at New York Presbyterian Weill Cornell Medical Center, and she is the chair of the Department of Pediatrics at Weill Cornell Medicine. This topic is very near and dear to Dr. Permer's heart, I believe, because her research focuses on infections in newborns. And thank you so much for joining us tonight, Dr. Permer.
Well, thank you, Dr. Platt, for inviting me and also for putting together such a great program. I am really happy also to be here in New York City at such a historic time that, after all that we've all gone through as humans in the last 9 months, we're just now starting to see those glimmers of hope from these recently approved vaccines. And I just want to say that, as a immunologist, as a virologist, as a infectious disease doctor, and just as a human, this is such a exciting time in vaccinology. That we've watched decades of basic science research that really collided with such an acute need that the world had through the introduction of this pandemic. We have the case that vaccine science will really rule the day, that we can already see those glimmers of hope from the recent data that has rolled out on how safe and effective these COVID-19 vaccines have been. And so I'm happy to be introducing this group who's going to go into all the details on what we know about the vaccines, what we're still looking to learn about the vaccines. And I also am a big advocate for bringing these vaccine innovations to children. And in fact, some of my research is focused there on how these vaccines work in a pediatric setting. And so more to come there. But thank you, Dr. Levine, Dr. Gerber, and Dr. Acker for leading us in this discussion. And thank you all for joining.
Thank you so much, Dr. Permer, and thank you to everyone who's joining us today. My name is Nicole Gerber, and I'm one of the doctors in the Pediatric Emergency Department at Cornell. And I'm excited to be joined by my colleagues, Dr. Deborah Levine and Dr. Sherry Platt from the Emergency Department, as well as Dr. Karen Acker, a pediatric infectious disease specialist. We all want this pandemic to be over, and it seems like a vaccine may be the way for it to end. But with all the information and misinformation, it can be hard to know if it's going to be safe to take the vaccines when they're available to you. So what we've done today is reviewed all of the available evidence and tried to summarize it for our presentation so that you can feel like you're making an informed decision. Just a quick note on terminology. The virus is actually called SARS-CoV-2, and it causes the disease, which is COVID-19. But because SARS-CoV-2 doesn't just roll off the tongue, for simplicity, we're going to refer to everything today as COVID. But we did want to point that out for clarity. So we're going to start with a presentation and then leave time for a moderated question and answer session at the end. Feel free to type your questions into the Q&A box as we go through. Two quick reminders. The first is that there's just so much information coming out all the time. Things are moving so fast, which has been amazing and exciting. But what we can say is that the information that we're presenting, we've worked really hard to make sure that it's up to date as of today, but things change all the time. And then the second thing to consider is that for the question and answer session, we're happy and excited to answer your questions, but we can't offer personalized medical advice. So getting started, next slide, please. Before we can understand how a vaccine works, we have to just understand in general how our bodies fight infection. So when germs, like viruses, like COVID, enter the body, they make us sick. And our white blood cells are like soldiers in an army that our body makes to help fight off the infection. And there are several types of white blood cells, but we're just going to mention a couple today. The first are the B cells, and the B cells make antibodies that attack the virus. So I like to think of this like Katniss Everdeen from the Hunger Games, who shoots out her arrows at the bad guys. And then even after the infection gets better, a few of these B cells remain. They stick around as memory B cells. They remember the infection, and if needed, they can restart the army really quickly. The other type of cells that we're going to mention are the T cells. And very basically, there are two sites. There are the helper T cells, which help out the B cells, and then the killer T cells, which attack cells that have already been infected. And then similar to the B cells, for the T cells, even after the infection is better, a few of those cells stay around as memory cells so that they're ready for a next time. So the first time you're infected with a disease, it can take a while to generate that white blood cell army and get your soldiers ready to fight the infection. And now, how do vaccines work and how they're made? So there are a lot of different types of vaccines, which all generally work by getting your immune system to ready to fight off the disease, but they use different things to prepare your body. So the easiest ones to understand are the ones that we're most familiar with, the ones that are used most often, which include either a weakened or inactivated virus. And that's what we see in the flu vaccines. The weakened or inactivated virus can't actually cause the infection because it's weakened or dead. But when it enters the body, your body can recognize that it's something foreign, and it can gear up those white blood cells and get that army ready to attack. The vaccines that are coming out about COVID now are mRNA vaccines. So in a minute, we're going to talk about what that means. And then just going back and putting it all together, so we talked about how normally when you are infected, you see those germs and your body generates the white blood cells. So what a vaccine does, it sort of tricks your body or prepares your body. It introduces something from the disease, like a piece of the virus, so that all of your B cells and T cells recognize that it's something foreign and bad. You build up your defense, you build up your army, you get those memory cells. So if you do actually then later get infected with the virus, your body has those memory cells and it's ready to start the fight immediately. So like I had mentioned before, the vaccines that are coming out and that are actually already available against COVID are mRNA vaccines. So we're going to spend a couple of minutes talking about what that is and what that means. To start talking about mRNA, you have to take it even a step further and go back to the basics. What are we made of? DNA. And so DNA is like the recipe book to make you. It's in the innermost aspect of the cell, the nucleus, and everything about you comes from your DNA. It controls your hair color, your eye color, and how your body grows and functions. So the next slide, so the DNA or the recipe book for you stays in that innermost part of the cell. So to get information around, your body makes messenger RNA or mRNA. What it is a small copy of a part of the DNA that's then actually used to make things called proteins. So it's like if you had a recipe book and then you copy down the recipe or part of a recipe onto a recipe card. The mRNA is like that recipe card. And then the protein is the apple pie or the crust of the apple pie or whatever it is that your recipe card will help you make. And like recipe cards, which in my house get lost or destroyed or thrown out, mRNA is quickly degraded or destroyed by the body. It's not something that sticks around for a long time. So what is the spike protein and what does that have to do with all of this? In the simplest terms, the spike protein is those little pointy red things that we see on the pictures of COVID everywhere. But in more complex terms, it's what actually helps the virus get into our cells. It's like the hand that opens the door to your cells. So the mRNA vaccines that are being made send instructions into our body on how to make that spike protein. It's like if your body then makes that spike protein, which gets your B cells and your T cells to recognize it, they generate that army, you get ready to fight the infection if you need to. And this way, if COVID ever tries to infect us, our body can say something like, wait a minute, I recognize this bad guy. Let me activate my white blood cell army. It gets those memory cells ready so that they're there and ready to fight an infection if need be. Next slide. So just to go back to the analogy one more time, and as a reminder, the mRNA in the vaccines is just for that spike protein. It's like if you had the recipe card just for the crust of the pie. It's not the whole apple pie. You would never call it apple pie. And in this case, you're just making the spike protein. You're not making the whole virus. You're not making even close to the whole virus, and it can't give you COVID. So the next two slides are going to go through the two mRNA vaccines in a bit more detail. The first one is the Pfizer vaccine, which requires 2 doses separated by 21 days. And I'm sure a lot of you have heard that this needs to be stored in freezing cold temperatures, -70 to -80 degrees. So it needs to be transmitted on dry ice. And it's really exciting because this one just got emergency use authorization by the FDA and is available in the United States now. They had a really large phase 3 trial, which had about 44,000 participants, meaning that about 22,000 got the vaccine and the other half got the placebo. And it's really exciting because it seems like it's really efficacious. Of the group who got the vaccine, only 8 participants developed COVID-19, and that's compared to 162 people who did not receive the vaccine who developed COVID. So that makes it 95% effective. The other thing is that only 1 participant who was vaccinated developed severe disease. So most of the other cases weren't severe. And then the other one that is being reviewed by the FDA and may have the EUA soon is the Moderna, which is also a 2-dose vaccine. It's separated by 28 days. It needs to be kept cooled, but it can be kept in a standard refrigerator. And they also had a large phase 3 trial, which has been completed. They had about 30,000 participants, meaning about 15,000 received the shot. And again, very efficacious. Only 11 people who got the vaccine developed symptoms of COVID, compared to 185 people who did not get the vaccine who developed COVID, and none of the vaccinated participants developed severe disease. So these vaccines really seem to be working amazingly well. And then the AstraZeneca vaccine is a different type of vaccine. It's a recombinant vector vaccine, but we are just going to mention it here because it has been in the news recently. And so we just wanted to bring it up to make sure that we were being complete. So just like kind of a quick overview of the vector vaccines. So they contained a weakened version of a live virus, but it's a different virus than the virus that causes COVID. And that virus, that weakened version of that virus, contains some of the genetic material from the virus that causes COVID inserted into it. It's called a viral vector. And that viral vector gets inside of our cells and it delivers the code to make the protein unique to COVID, that same spike protein. So it's kind of like if you put that recipe card inside of a recipe box, but if the box was a virus. And one of the reasons that the AstraZeneca vaccine has been in the news a lot, they also have very large phase 3 trials. But interestingly, in one of their groups, the participants accidentally got a half dose as their first dose of the vaccine. And then they went on to get a full dose as their second vaccine, compared to a second group, which got 2 full doses. And this wasn't on purpose, but what came out of it is that in that first group where they got that half dose initially, the vaccine was about 90% effective. And in that second group where they got 2 full doses, the vaccine was about 62% effective. So overall, they report the vaccine as being about 70% effective. But what we wanted to kind of point out from this, it's been in the news a lot. They've been talking about it a lot, but I think this is actually great because we are hearing when something happens that's different than what we expected. This wasn't on purpose, but this information is out there, it's available. It looks like it might have been a good thing anyway. And the fact that we're hearing about it is really reassuring to me. And so before we move into the next section, this is kind of our light at the end of the tunnel. The COVID vaccines aren't going to make this pandemic end abruptly, but hopefully Over the next couple of months, as more and more people get vaccinated, we're eventually going to start to reach levels of protection that are going to make our everyday activities a lot less risky. And so for the second half of our presentation, we're going to go through some myth busters because we know that there have been a lot of concerns about the COVID vaccines, and there are a lot of things out there that just aren't true or things that we might just not know the answers to yet. So what we tried to do is list out all of these myths, or as many of these myths as we could, and then talk about where they came from and why they aren't true or what we still need to learn. And so to start off our Mythbusters, I'm going to introduce Dr. Karen Acker to start with our first one.
All right, great. Thank you so much, Dr. Gerber. So we're going to start with the first myth that we've been hearing a lot about. It concerns that the vaccine was made too fast, as exhibited by the name Operation Warp Speed. So actually, though, the vaccine was made fast, but also wasn't too fast. And so there are many reasons why the vaccine was able to be made so quickly. So number one is money. It usually takes a lot of money to develop a vaccine, and then even more money to get it ready for distribution. And money just wasn't as much of a factor for COVID vaccine development. Thanks to Operation Warp Speed, the government was able to fund a lot of the vaccine development, so companies didn't need to front the money and take that risk. And additionally, companies started mass producing the vaccines before they even knew if they worked. And that usually is not a financial risk that anyone's willing to take. So rather than doing steps sequentially, many steps were just combined and done at the same time, and they didn't actually skip any steps. Number two, mRNA vaccines are actually really cool technology, and because they're able to be made so much faster and able to be produced faster than other vaccine technologies. This is why the two first vaccines we're seeing are mRNA vaccines. Number three, although there aren't any mRNA vaccines currently in use in humans, the technology actually isn't new. People have been working on it for years, and there was already a lot of safety data out there. And then lastly, literally everyone in the world was working on this at the same time. COVID was sequenced just a few weeks after we learned of its existence, and the work started immediately. So it's certainly, this situation was unprecedented, and vaccine work was able to be faster than it ever has been before. So actually, it's interesting from this process, because probably we should look at it the other way, that it probably takes too long to make vaccines in general. So the next myth that we've been hearing a lot is that it hasn't been tested on enough people. And actually, that's, I would say it isn't true. The phase 3 trials are actually comparable to many other vaccine trials. As an example, the HPV vaccine was a 30,000 person trial, and the rotavirus vaccine was a 70,000 infant study. So far, the Moderna trial has about 30,000 people, and Pfizer has about 44,000 people that were included in their trials. So I'd say that's pretty comparable. So another myth is that mRNA vaccine can change my DNA. So I've heard that because I just think when we hear the terms DNA or RNA, that's something we worry about. But actually, so this is actually not biologically plausible, and the mRNA vaccine cannot change my DNA. So we make messenger RNA all the time, and it doesn't change our DNA. What's both good and bad about mRNA is that it breaks down very quickly. So of course, this makes it more difficult to keep it stable when we're trying to transport it, as you'd heard about the freezing temperatures. But when it's in our body, it goes in our body, makes the protein, but then it gets degraded within hours to days, so it won't stick around forever. And additionally, and most importantly, it won't get anywhere near the DNA, which is protected in a different compartment from the cell, in the nucleus of the cell, which mRNA does not get into. So go back to our analogy. The mRNA is the recipe card, and the DNA is the cookbook. And the recipe card can't suddenly become part of the cookbook. So the next myth is that there's never been an mRNA vaccine. We don't know if they are safe. So although we haven't had an mRNA vaccine in use, we do have other mRNA vaccines that have actually been made. So while it's true that we don't have any current ones, it's actually not new. So scientists have been using mRNA for decades. The first successful use of mRNA in animals was reported in 1990 but it initially wasn't that popular. However, more recently, there have been more technological and research advances that have increased its appeal. The mRNA vaccines have several beneficial features because one, they can't cause an infection. There's no actual virus in the vaccine. Two, as I said before, it can't integrate into our DNA and cause mutations because they don't go near our DNA. And three, they're quickly broken down, making them a safe option. So there are actually multiple benefits that were talked about for years, but because when anything's new, it takes a while for it to come into play. Additionally, mRNA vaccines actually have a much higher ability to be more effective than other vaccines. And what is important during this pandemic is that they can be made rapidly and inexpensively and in large scale to the way that they are made. They have been studied in animals and there are already a lot of human trials, as we know. And additionally, there's been prior human trials for infectious diseases, including HIV, rabies, Zika virus, and influenza virus, and for cancer treatment that uses mRNA. So there are actually a lot of cancer trials currently underway, even some phase 3 trials. So that gives me a lot of reassurance that we actually know a lot more about mRNA than we had thought. So let's go to our next myth, that there hasn't been enough time to see side effects from the vaccine. So this is actually a pretty interesting point because most vaccine side effects are actually picked up within 2 months after receiving the vaccine. And that's the case with all the vaccines we've seen. The really, really rare side effects that we see aren't typically picked up in the phase 3 trials. So for example, I'm going to list a few very rare side effects that were all picked up within 2 months of that vaccine being available. So one is from the polio vaccine. There's an oral polio vaccine that does contain live polio virus, and it can cause polio infection, but it occurs in 1 out of 2.4 million cases. Another example is something called Guillain-Barré syndrome. It's a neurological syndrome that has been seen following flu vaccine. It happens in about 1 per million recipients. And this is still less often than how often it occurs just normally in the population. And then one other example, yellow fever-like illness in people who have received the yellow fever vaccine, and that occurs in 1 per 1 million recipients. So those are extremely, extremely rare side effects that were picked up within the time of the phase 3 trials. Additionally, to give some reassurance about vaccine safety is that we have multiple vaccine surveillance systems prior to the pandemic that have been available. So one main one is called the Vaccine Adverse Event Reporting System, also known as VAERS. There's another one called the FDA BEST. There's the FDA and Centers for Medicare and Medicaid Services Partnership, and others. And additionally, there's a new safety mechanism that has been implemented with this vaccine. It's called vSafe. And it's basically, it's an app that every individual will have access to download and to be able to report any symptoms that they have potentially developed after the vaccine. And the CDC has a group that monitors all of these mechanisms to monitor symptoms, and they review it every week, and we will hear about it as soon as it happens. All right, so the next myth is that you can get COVID from the vaccine. We haven't heard this as much, but this is definitely always a concern with vaccines that I've heard in the past. And so I just want to really reassure everyone that you can't get COVID from the vaccine. It's not biologically plausible. None of the vaccines have any actual SARS-CoV-2 virus in it. So you can't get that viral infection or COVID from the vaccine. It's literally impossible. You may not feel well the next day, but that actually means the vaccine is working because it's getting your immune system ready. And when your immune system's active, you sometimes don't feel great. The actual data from the vaccine trials has less than 10% reporting severe side effects. And this is the data from the Moderna press release. And this slide that you see up here actually has some information on general side effects from the Pfizer vaccine. And then I also want to show how it compares to Shingrix or the shingles vaccine, which is known to cause some discomfort in the few days after vaccination. But then I also want you to compare it to the placebo panel. So although it is tempting to look and say, wow, over 40% of people who got the Pfizer vaccine developed headache and fatigue, it's going to make me feel sick. About 30% developed those same symptoms in the placebo group. And so that's actually not that big of a difference. So the next bits that we're going to go into are regarding vaccine development. So I'm sure that everyone has heard recently from the UK when they started administering their vaccines about 2 healthcare workers that developed severe allergic reactions. So I just wanted to go over what the scenario was about. So this was picked up in the news, and it kind of made it sound like it was some new and dangerous and unexpected response to the vaccine. It really wasn't. Although the rates of allergic reaction in the vaccine trials were very low and almost the same in the vaccine and placebo groups, about 0.5%. They did exclude people with severe allergic reactions from the vaccine trials. And that's because that anyone with a history of a severe allergic reaction are at risk of having severe allergic reactions, really when you introduce anything new into the body. So it's always a potential risk. Both of the healthcare workers in the UK did have history of severe allergic reactions for which they carried an EpiPen. And so they both did fine after the vaccines. So what has been amazing from this scenario are multiple things. So one is that both of those people are doing fine. 2, we heard about it right away. And 3, a thorough investigation is underway to understand what happened and why it happened so that we can make sure it doesn't happen again. So let's go through another myth that you may have not heard about, but it has come out. So I want to make sure we go through that, is that you can get HIV infection from the COVID vaccine. So we have to kind of go back to explore where this came from. It came from prior trials for HIV vaccines in 2008 and 2011. And these vaccines were an adenovirus vector vaccine, akin to how Dr. Gerber talked about the recipe box delivering something. And the initial studies show that the vaccine didn't work, but on follow-up, they found that there were higher rates of HIV in the group that received vaccine. They weren't able to figure out exactly why, but what's important to remember is that they didn't get HIV from the vaccine. These were groups that were already at very high risk for getting HIV based on just their risk behavior. And that group happened to have higher rates of getting HIV infection. So overall, it seemed that the vaccine increased the risk in people who are already at higher risk for HIV, especially uncircumcised men, and it didn't really seem to hold up for women. So this might be important globally or for people who engage in behaviors that put them at higher risk for HIV. And the next final myth that I'll go through before passing on to Dr. Levine is about infertility. So we've heard a myth that the COVID vaccine can cause infertility. And so I want to explain that this is very unlikely to be true. So again, we have to kind of start to explain where this comes from, where this idea comes from. People have speculated that antibodies directed against the COVID spike protein will cross-react with a protein in the placenta because of similarity between the proteins. But if you actually look, the similarity is so small between the 2 proteins that there isn't actually a way that there would be any cross-reaction between the 2. And also, if this were the case, there would be a cross-reaction with actual COVID as well. And if that were happening, we would expect to see high rates of miscarriage, which we aren't seeing. So now I would like to introduce my colleague, Dr. Levine, to go over some more myths that you may have heard about COVID vaccines.
Thank you, Dr. Acker, and thank you for being here and listening to our talk about safety. So the first myth I'm going to talk about that we've heard is I don't need the COVID vaccine because we will all have herd immunity soon. So unfortunately, this is not true. We are nowhere near herd immunity. Even though there's so many people who are affected by COVID, that we only have about 20% probably of our population, and we need much more to develop a herd immunity. And that's not how pandemics historically have ended. The 1918 influenza pandemic didn't end that way, but we are close to achieving a herd immunity, and that is through the vaccine. And since the vaccines are over 90% effective, the thought is that if we vaccinate approximately about 60 to 70% of our population, we may be able to achieve a herd immunity, which is exciting. The next myth is that natural immunity is somehow better. So I'm going to dispel that myth and tell you that natural immunity may be, but isn't always better. So, for example, if you take the HPV vaccine, it helps produce a much longer lasting immunity than natural infection. The tetanus vaccine produces a strong immune response, and vaccines against pneumococcus and meningococcus help to make the immune system extra robust. So if you can see on the slide, there's two pictures, and one is natural penicillin and one is man-made penicillin. And we know that even though natural may be better to some, we'd probably all rather take the man-made form of penicillin any day. So the next myth we've heard people talk about is that I don't need the COVID vaccine because I've already had COVID. So that is not true. You need to get the vaccine even if you've already had COVID. And that's because we don't know how your personal immune response is going to be. We don't know how long it's going to last, and we don't know if it's going to be as robust as the one from the vaccine. And most trials have not excluded patients who have had COVID in the past. There were about 3% in both arms of the Pfizer trial. So, we recommend getting it even if you've had it in the past. So the next myths we're going to talk about are unfortunately things that we don't know the answers to. So we will need a COVID vaccine every year like the flu shot. So we don't know that. We're not going to know how often people are going to need to get the COVID vaccine. What we do know so far is that the virus that causes COVID-19 is different than the flu virus because it doesn't seem to be mutating the way that the flu virus mutates every year. So hopefully this may not be the case, and hopefully we may not need it every year. But participants in the trials are going to be followed, and we'll learn more about this over time. The next myth is that the COVID vaccine is not safe for children and pregnant women. So this is probably not true. We're always hesitant to try out new things on pregnant women and children, and we don't have all the answers yet. Both Pfizer and Moderna have started enrolling children as young as 12, and currently the vaccine is indicated for children 16 years and greater. So we're going to have more information coming out soon. And then the information about pregnant women, there are few women who were enrolled in these trials, even though you weren't supposed to be pregnant at the onset of enrollment. They might have become pregnant during the trials after receiving the vaccine, and those patients, the small subset, will be looked at. But the thought is that it's relatively safe from animal studies and the trials, and the Society for Fetal and Maternal Medicine has come out with a statement recommending that the vaccine be offered to pregnant women as well as breastfeeding women. And there's going to be some trials enrolling pregnant women to really learn more and get more answers. The next myth is a tricky one. The COVID vaccine will prevent me from getting COVID. So what we've seen so far is that the COVID vaccine is very effective at preventing people from getting ill with COVID-19 or symptomatic disease, and certainly worst case scenarios being hospitalized. But it seems that there's still a possibility that you may have an asymptomatic infection, and you may be able to spread this virus to other people who may be vulnerable. And also the efficacy is not 100%. So this is why we all are suggesting you continue wearing your masks until we have developed a large herd immunity in our patient population. And hopefully more information will come from the studies that are still ongoing. So thank you all for joining us today, and we hope we answered many of your questions about the safety of the COVID vaccines. We are so grateful to New York Presbyterian for giving everyone in the emergency department the opportunity to receive the COVID vaccination this week. And here are pictures of me and my colleagues getting vaccinated. So at this time, I will pass the microphone to our Division Chief, Dr. Shari Platt, who will moderate the question and answer session. Thank you.
Thank you so much, everybody, and I appreciate all of that wonderful information. So I'm going to moderate the Q&A, and I have some very interesting questions that I will now pose to our panelists. One of the first questions I think pressing on everybody's mind is what we know about children. Now I know that Dr. Levine just mentioned it, but I would like to just reiterate about when toddlers or children will get tested for the vaccine and when perhaps they might actually receive the vaccine. So anybody?
So like I said, they are, I think, systematically looking at the ages younger and younger. So currently now the vaccine is indicated for ages 16 and greater. They are doing a study currently as young as 12. And I suspect as all the information comes into play and safety is more assured with large numbers of older patients, they will start to do studies on younger and younger children.
Thank you. And I guess to that point, perhaps one of you can comment on what is the order of distribution and has that been determined?
Yeah, I can comment on that. Thank you, Dr. Platt. When deciding how the vaccine would be distributed, already hospitals, we were all meeting. We were meeting with ethicists. We were meeting with leadership. And at the same time, the CDC and Department of Health were all determining. And the CDC had recommended that healthcare workers and residents of long-term care facilities are the first to receive the vaccine because those are the populations that are most often confronted with COVID. So as of this week, those populations have started to be vaccinated within the healthcare community. And we've started with the emergency room workers and personnel. So that's not just doctors and nurses, it's really anyone who interfaces with the emergency room. Those are the people who clean the emergency room, who transport patients, who people are going into the emergency room, even if not always at front facing with patients. And this is also really important for the equitable distribution of the vaccine, which is, we understand, is very important, especially given that COVID affects underrepresented minority populations disproportionately. Additionally, ICUs workers have been vaccinated as well. But we're really hoping and seeing that we're probably going to get a lot of more supply pretty quickly so that it won't really seem like it's so staggered, and hoping that soon everyone will be getting vaccinated.
And Karen, while you're commenting on that, can you comment a little bit on when will the average healthy person in the community receive the vaccine?
Yeah, so, as we know with this pandemic, everything's in real time, day by day. So we're thinking by the end of the spring that it will be available for sure to the population, but if it could happen earlier, it's possible. It really depends on how quickly we know that the Moderna vaccine is going to shortly be approved, or if it hasn't already, by the FDA. Everything's in real time and we'll be getting more supply. And so can't predict exactly, but during the spring is when I anticipate.
Right. And what about adults with underlying disease? Can you comment on adults with diabetes or Crohn's disease? Will they be prioritized, and or should they avoid getting the vaccine? Two-part question.
Yeah, that's a great question, because I know it concerns many, and we know that there are multiple comorbid conditions that could increase your risk for severe COVID. So we definitely want to protect those people. So the Pfizer trial did include patients with underlying comorbidities. I don't know the exact details of every type of comorbidity, but included patients with, diabetes and certain autoimmune conditions. And as we know, we didn't see any serious adverse reactions in those study participants. I don't think that there's any reason why those people with comorbidities will have high risk for adverse reactions, just from a biological plausibility standpoint. Sometimes if you are on a medication that suppresses your immune system, you're sometimes not able to mount as good of a response to a vaccine. That is possible, and we will certainly learn more about that as that goes on. So that's why, as we learn more, we still encourage that everyone still practice the same precautions that you're practicing.
Just to add to that, we may not, like off the top of our heads, remember all of the different comorbid medical conditions that people who participated in the studies have, but that information is available. The Pfizer data was published in the New England Journal of Medicine. The AstraZeneca study was published in Lancet. I'm sure the Moderna study is going to be published very soon. So all of that information is out there and available to the public.
Right. A little bit more about the vaccine and the making of it. Can somebody comment on how does making the spike protein influence the development of the B and the T cells?
I can take that one. So like we talked about in general, when your body sees something like a virus that's foreign, your body recognizes that it's foreign. It's not something that belongs inside of you. And so you make the B cells and the T cells and that whole white blood cell army to fight it off. So with the vaccine, the mRNA gets your body to make that spike protein, and your body, even though it's made by your body knows that it's not something that's intrinsic to you. And so it still is able to recognize it as foreign. And so your B cells and your T cells get excited and they get involved, and they start forming their army.
Right. And a little bit related to that is that how do they know that the antibody produced by the vaccine is any better than the antibody produced by actually having had COVID?
Yeah, well, that's, something we'll definitely learn as we go on, because, we're still only a few months outside of those study participants getting the vaccine. What we do know in terms of natural immunity, we are seeing that reinfection is possible, although not very common. It certainly is possible. And there are still not everyone who has the vaccine will necessarily mount an effective antibody response. And we still have to learn a lot about that. The issue is that even if natural immunity were as good as the vaccine, by getting natural immunity, you are putting yourself at risk for actually getting sick or possibly dying from COVID. And so that's a risk that I don't think anyone should be willing to take, even for the sake of getting that natural immunity. But from what we're seeing so far, it's thought that the vaccine will induce more robust immunity than the natural immunity.
There's a question about about allergies, allergies to the vaccine. One is, will there be any type of allergy testing prior to getting the vaccine? And then the other one is that if somebody has like the EpiPen, would that be helpful? Or if you have a known allergy, would that be a contraindication to taking the vaccine?
So I think if you have a known allergy to a specific component in the vaccine, that would be a contraindication. In general, they're recommending that people who have a history of anaphylaxis, a history of a severe allergic reaction, be cautious about the vaccine. And we are observing people for a brief period of time after they receive the vaccine to make sure that they don't have a severe allergic reaction. But I think it's something that really needs to be thought about on an individual case-by-case basis. And is definitely something that if you have a history of an allergy, that it's a great question to discuss with your allergist.
Can I just add something that all the ingredients for at least the Pfizer vaccine are also publicly available. And they're really recommending that if anybody has had a severe reaction to any of the ingredients in the vaccine to speak to their doctor first. So it's all publicly available.
And I know we've talked a little bit about this, but there are questions about giving the vaccine to children with underlying disease. or immune compromised. So for example, a child with underlying lung disease, or a patient, a person who has had a transplant, if they're immune compromised for any reason. Is that a reason to give the vaccine or to not give the vaccine?
I think we obviously will have a lot to learn when they start trying the vaccine in children. But from, as I said before, a biological plausibility standpoint, I don't see how the mRNA vaccine will actually be concerning for someone who's immunocompromised, other than maybe not generating as good of a response as we would like. And so it's not like certain vaccines that may contain live virus, which we do avoid in patients who are severely immunocompromised. That is not the case. mRNA is just basically a component that is allowing your body to make a protein. And so nothing infectious in there. And that's really the primary concern when we think about patients with immunocompromising conditions. Even though we're not seeing that children are as severely affected as adults are, there still are at risk for severe disease. And there's concern that potentially we're still trying to learn exactly whether patients and children with immunocompromised conditions have increased or decreased risk to disease. But certainly when you have underlying comorbidities, there's concern that having a COVID infection could result in severe disease. So it's certainly a population I would want to protect. But I can't answer that for sure, but I anticipate that it will be as safe for children as it is for everyone else.
Thank you. And there are some questions about the storage of the vaccine, and if the vaccine is not appropriately stored, does it have the same efficacy? Would it be harmful to take it, or would it be weakened in any way?
I can take this question because I think it's the coolest thing ever. So Pfizer knows that their vaccine needs to be kept freezing cold and needs to be shipped on dry ice. So they are shipping the vaccine with temperature sensors. And what they did is before they actually started shipping the vaccine, they did test runs to make sure that they could keep the storage containers at the correct temperature. So they just shipped them with temperature sensors to make sure that they remained at the correct temperatures. So we will know that the vaccine has been at the correct temperature for the duration of its travels. And the reason that it needs to be kept cold is because the mRNA degrades easily. So we're talking about like concerns about it staying in your body or something, but it's this really like fickle thing that if it gets a little too warm can degrade. So it's not something that would stick around forever.
Thank you. I think this might be one of the most important questions, and I want to raise it before we get to the very last minutes. If everybody gets vaccinated and the vaccine is so wonderful at 95% effective, do we have to still wear masks? And if it doesn't, this is a part 2 question too, if it doesn't really block somebody from having asymptomatic COVID, do we still need to keep our distance?
So I think the answer is for right now, yes. For right now, we don't know for sure whether the vaccine can prevent you from being like an asymptomatic carrier. My thought and hope is that eventually we are going to see that once you've been vaccinated, you don't have that risk. But for right now, because it is still a possibility, we do still need to be wearing masks and maintaining our distance. And the other thing to consider is that it's 95% effective, and that's amazing, but there's still that 5%. And so right now in communities where the rates of COVID are really, really high, that can still end up being a lot of people who end up getting sick. And also, especially now, while we still don't know if it's okay to be giving to children, it's important that the adults are getting vaccinated and continuing to wear masks so that we're not spreading it to the people who are unable to get vaccinated.
Yes, and just going on Dr. Gerber's words, the hope is that when there's enough people who are vaccinated in the country, that we reach some critical amount and there is herd immunity, that perhaps then maybe the prevalence rate of the virus will go down so significantly that there'll be a time when we don't have masks. That's if we all get on board.
Okay. Thank you so much. There's been amazing questions, and I would love to give Dr. Permer the opportunity to wrap up and see if she has any other important last minute thoughts and pearls for everybody, words of wisdom. Thank you so much again, Dr. Permer, for being here.
Yeah, well, you all did a fantastic job of really boiling down some really complex science into some really great graphics and very simple terms. And so great job on that. Yeah, I'm just really enthusiastic that there is so much interest about when the vaccine will be ready for children in particular. I think it's really remarkable how quickly the vaccines have been tested in children already, because often children, pregnant women are left out of these initial trials. And I think what we've really seen here is the scientific community come around to make sure that those populations are not left out. And so there is good news that the vaccine is planned to be tested in toddlers from some of the companies. And I've been working in animal models that shows that yet very young animals can respond very well to the mRNA vaccines. And so we are, I think very hopeful there. Also very important about the pregnant women who were not included in the trials, but it's really remarkable that the groups that reviewed this vaccine felt so strongly about how safe they appeared in adults and how effective they were to give pregnant women the choice as to whether they would like to get vaccinated, even though that population was not included. And so, those women, I think, are weighing their risk of how much they're exposed and at risk for COVID versus, how much potential risk there is from just not having as much information in that population. And then for lactating women, I would just say, as someone who's studied a lot of breast milk immunology, I only see upside really for lactating women to get this vaccine, deliver those antibodies to your baby. There's very little chance that that mRNA would even end up in the breast milk. And if it got into the baby's GI tract, that wouldn't be a bad thing either. So I wholeheartedly endorse lactating women getting this vaccine. So I think, like you heard from the panelists, keep watching this space because things are changing daily. And of course, keep watching how the vaccine rollout is going to know when this vaccine is going to become available for your group. Looking on the CDC websites and other places that talk about, what groups will come up next for vaccination after healthcare workers, so that when you can go to your local provider or your local pharmacy to ask for the vaccine. And thank you all for your interest in this webinar, and clearly your interest in playing a role in ending this pandemic, because it's going to take everybody. And so we really appreciate your attention to this and questions.
Thank you very much. And thank you to everybody for joining today. And I think this concludes our webinar. Have a very happy holidays and be safe.
Thank you.
Holidays.